I'm zooming out to like a whole family, because as soon as we start triple feeding, we're taking up all the resources. We're taking up all the time for showering, all the time for connecting with an older sibling, all of the time to walk the dog, all of the time to talk to your mom on the phone, all of the time to sleep, most importantly, and we're putting it all towards feeding that baby.
Welcome to PedsDocTalk TV and this episode of the PedsDocTalk Podcast, where you can catch my amazing conversations with guests on the show here on my YouTube channel, or if you prefer audio only, wherever you access podcasts. I'm Dr. Mona Amin, a board-certified pediatrician, lactation consultant, and mom of two, and I'm here to uplift, support, and guide you so you can raise those incredible kids. Let's get to today's amazing conversation.
So today's guest is Victoria Facelli, a fellow IBCLC-lactation consultant, author of Feed the Baby, who is changing the way we talk about feeding our babies. And she's joining me to talk about why we hate triple feeding and what to do instead. Thank you so much for joining me today, Victoria.
Hi there. It's so great to be here. Thanks for having me.
Yeah, finally able to connect, and I'm so grateful. You know, I'm a newer IBCLC in my training, and I love connecting with other IBCLCs and lactation educators on the show and talking about this topic that I think so many mothers deal with and don't understand the frustration of it until they actually get into it, or are frustrated by it and don't know other options about what they can do if they hate triple feeding. But before we get into that conversation, tell me more about yourself, why you became an IBCLC, and also your book, Feed the Baby.
Yeah, so I became an IBCLC actually a long time before I had my kid. So I was a postpartum doula and then a lactation consultant, and then I became a mom. And so that objectiveness that I was able to bring to my early career was so great. Like, I wasn't carrying any of my own baggage and experience into it. I live in North Carolina, and the University of North Carolina has this really robust inpatient training program. So we do a lot of research. We do a lot of direct education. And then also we're in birth centers, outpatient clinics, small community hospitals, giant NICUs in Eastern North Carolina, like really saw such a big span. And it was so great to get such a big perspective as an early IBCLC, and really started to develop some of my ideas and thoughts and kind of my own perspective on this field. And I was always like pretty chill with formula in a way that not everyone was. And I was always sort of like more interested in the big picture of how the whole family is doing. Yeah. And then when I had my own daughter, I had a traumatic birth. She was not able to nurse. I felt sort of backed into a corner with exclusive pumping. I don't think everyone feels that way. I think some people feel really empowered with exclusive pumping. I think exclusive pumping now versus 5 years ago is so different because of the different tools. But that was really my experience. And so when I sort of came out of the fog of the trauma of having my daughter, my therapist told me I needed to do something that was about me. And that's when I wrote Feed the Baby, which is my love letter to all kinds of parents. It's an inclusive guide to nursing, bottle feeding, and everything in between. And it's sort of a choose your own adventure, because that's really what I see families needing to do. And I didn't want to make one style of feeding the most important thing, because the reality is at some point over a kid's first 2 years, you're probably going to use all the tools. Like some folks really are just going to use one tool, but it's pretty rare that people just nurse and never pump, or people like just formula feed and never ever latch. You know, like there are definitely those instances, but they're pretty rare. And so what I wanted was for people to be able to see their stories reflected, tell really diverse stories, and also give these really concrete tools. And it was so fun to write the book. I had a really great time with it. And now I'm sort of trying to find my way into what's next and figuring out what really grounds me in this work. And the thing that I keep coming back to, that I think you come back to as well, is where is the place of mental health in the feeding conversation?
Yes. And I resonate with you so much on that. And I think we have both personal and professional experience on that as well. My journey is different, as you know, and maybe my listeners don't know, but I was a pediatrician first. I've always wanted to get my IBCLC because most people know you don't get a lot of that training in pediatrics. But I was like, I wanted to do it, but the time, right? The credentials and the coursework. And then after working for 10 years, I had so much experience with families, right? Talking to them, learning, shadowing other IBCLCs in my hospital that I round at. And so then I became an IBCLC after the traumatic birth I had with my son, and feeling like there was a lack of understanding of pumping education, a lack of understanding of the combination feeding. And so I felt like maybe I can be that voice for someone who may need nursing, but more so maybe combination feeding or maybe exclusive pumping. And I did my own work on that. Like you did. I have not read your book. And by the way, I'm going to read your book because, like I said, as a fellow IBCLC, I think I'm going to learn so much from you. And I think that's so awesome that we can connect that way. And what is your personal and professional experience with triple feeding, and why using that term, why do you hate it so much?
Yeah, it's so funny. Like, my mentor and I really can get into it about triple feeding. She's been in the field a lot longer than I have. And I think part of what's really important to me is to remember that providers are people and they have a lens, right? So like when you were just a pediatrician, you had this lens of like, you're really looking at the baby, like you're looking at the whole family, but like your patient, you're vaccinating that patient, you're weighing that patient, you're like making sure that that patient is healthy. And so, and then understanding also like what's someone's scope, what's someone's education, right? So as a pediatrician, your scope is like newborn all the way to 18, right? You're doing everything from like puberty and hormones and broken bones and RSV and all of that stuff, and infant feeding, which really to do well takes 2 hours. And that's years of training, right? So we have to also understand that our pediatricians aren't necessarily experts in infant feeding.
Yes.
They're experts in growth curves. They're experts in baby, like assessing if a baby is healthy and well. And they're such a great resource to talk through things with, like, right? They're sort of like the head of this larger team. But I think what really gets me with triple feeding is that when a pediatrician sees a baby who's not gaining weight well, it is often the only tool they have. They're like, I know I need to protect production, like milk production. I know I need to get this baby gaining weight. I do not have the time and nuance to really figure out why this is happening and what is happening. But pumping plus formula feeding plus offering nursing, like maybe if we just do everything, like it'll work it out. And that is understandable and without nuance. Right? Like I understand why that's the easy first place to go.
Yeah.
But what often doesn't get talked about, so like there's different people who might recommend triple feeding. The first one is pediatricians. And where I often see the problem there is not getting to the why. Like, is there a plan to figure out the why? Like if a baby is not transferring, is it a supply issue? Is it a tongue tie? Is it a like torticollis, like a body issue where a baby's holding tension in their body? Are they like, do they have an allergy? Like those are pretty rare, but like, are they not absorbing well? Like we actually have to get into that why. And since half of that equation is not your patient, it's very difficult to get into that why a lot of the time. Yeah. And there's not time, and they don't like see our kiddos as often as other providers do. So that's like one piece of it, is just sort of the idea of like, I don't know, let's just do everything.
Right.
And then you're left with no plan. And then I also see lactation consultants recommending triple feeding, and that comes from a different angle. So I feel like pediatricians are recommending triple feeding because they want to protect a baby's growth. Right? That's why my book is called Feed the Baby. Like, that's our rule, right? First, feed the baby. We don't do anything else till that baby's fed.
Right.
Right? Like, I work in a tongue-tie clinic one day a week. Like, if a baby is not gaining weight well and I don't have permission from their pediatrician weight-wise, I'm not touching that kid. Like, first we feed the baby. So that's their perspective. And then I think a lot of lactation consultants are so fixated on nursing that they can't let that part go. So ideally, they're working interdisciplinary. They're looking really closely. They're trying to figure out like the why of that baby's low transfer. But in the meantime, they're so focused on direct nursing being important or milk production being important that they're a little stuck too. And so where I get in there is I really am zoomed out to like, okay, there's 2 patients or more in front of me, right? In the case of multiples, maybe more, but we'll start with 2 patients in front of me. And actually often a third, if I'm including a partner, right? Or sometimes like a sibling who has a lot of needs, right? So like I'm zooming out to like a whole family, because as soon as we start triple feeding, we're taking up all the resources. We're taking up all the time for showering, all the time for connecting with an older sibling, all of the time to walk the dog, all of the time to talk to your mom on the phone, all of the time to sleep, most importantly. And we're putting it all towards feeding that baby. And one of the things I talk about is that, like, I don't believe that breast is best. I don't believe that breast milk is inherently better, because you can't generalize like that. Every choice we make has trade-offs. And we cannot assume that we know those trade-offs for another individual. So when we decide that we're going to triple feed and we don't acknowledge those trade-offs, that is where I get protective.
Yeah.
And so my experience of triple feeding, so when I was in practice, I would just like see families who were just undone by triple feeding. And I was like, we got to do something about this. Like, this is horrible. Like, we are torturing these people. Like, sleeplessness is used as torture. Like, you can actually torture someone by not letting them sleep.
Yes.
And so if we tell them the most important thing you can do for the health of your child is breastfeed them, which in the way I read the literature is a little heightened.
Yes.
And then we're like, and in order to achieve that, you're not allowed to sleep. You're like, well, this is the most important thing in my life. I love this person more than anything I can possibly imagine.
Right.
I would do anything for her. I'm going to completely sacrifice myself. And so for me, I had started from the NICU. I had started from trauma. I had started from a kiddo that was struggling to eat. Like, she was using an NG tube. We were like trying to stave off needing a G tube surgery. It was a very heightened experience. And so I threw everything into pumping. I was like, I'm going to fix this kid with my breast milk. Now, here I am 5 years later with a happy disabled kid. And I'm like, actually, health is a lot bigger than that, honey.
Yeah.
And like, food is a lot bigger than that. And the way we share meal times is so much bigger than that. And guess what? We're still doing feeding therapy. So for me, we decided to prioritize bottles and just like get the heck out of the hospital. And she was able to do bottles. And then we came home and I started working with everyone I could find to try to figure out if she could directly nurse. And I really like came to a point where I realized that working on that skill was obscuring everything else. And so I let it go.
Yeah.
And then, like, honestly, for me, in the time I was in, being stuck on the couch plugged into a large pump that was outside of my bra, which now, like, we have such a bigger variety of options, while I was actually having my own health crisis. So I had like physical trauma from my daughter's birth. I was losing weight. I was fading. Like, you ready to hear something gnarly?
Yeah.
I had a colonoscopy 4 months postpartum after an unhealed 4th-degree tear while exclusively pumping.
Oh my gosh. Like we talk about looking at this as a whole family approach, right? Like, that is, the mother is healing so greatly there, and we forget how much that is for her body, including when you're producing milk. I mean, I can relate to this so much. I went through so much to do all this too.
Yeah. And now I see people like with all the tools we have for pumping who are like comfortable and joyful and pumping at their
Yeah.
kids' little league game inside their shirt and putting stuff into a milk chiller and like they're
Yeah.
having a
Yeah.
great time and it looks
Yeah.
totally different and also might not be for you.
Yes.
And also formula can be healthful,
Yeah.
right? Like
So if
these
someone's
are
not
not
familiar with the
binaries.
terminology, which I think maybe we could have discussed, what
Yeah.
exactly is triple feeding for someone who may not be familiar with the terminology of triple feeding?
Yes. Thank you for bringing me all the way back. So when we're in those early days, babies nursing or pumping spikes our hormones to tell our bodies how much milk to make. It's a pretty sensitive supply and demand process at that point. Meanwhile, full-term healthy babies are born with fat stores that give us a little bit of wiggle room while milk transitions, while our bodies do that process. And by 2 weeks, we want them back at their birth weight and gaining weight on a curve. I don't care which curve it is, but we want them growing on a growth curve. And those are the two things that we're sort of really focused on those early days. Some babies are born unable to do that effectively. That could be a tongue tie. So maybe that parent is in a lot of pain with nursing, or maybe they're not able to effectively make a suck that drains milk. So that could be from torticollis, which is tension in the body that can cause difficulty with suck. That could be a tongue tie. That could be something that is undiagnosed. It could also sometimes just be a little time to figure it out.
Yeah.
And so what often gets recommended is that you do a system where first you offer nursing, then you pump and give them a bottle, either of what you've pumped and or additionally formula, right?
Correct.
So the idea being that the pumping is protecting your supply while the supplemental bottle is making sure we're seeing food go into that baby to protect that we know they're gaining weight. And like, the problem is, we don't have a plan to get off that road.
Yeah.
And often, like if a baby is not eating well, that means that you're often spending a lot of time trying to get a baby who doesn't want to latch, or nursing a baby who can't effectively suck anyway. So it's taking a really long time, and or it's causing tissue, nerve damage, and pain.
Yeah.
Right? So like we're doing something that's not working for hours on end. Like sometimes, it can take an hour to get a baby who's really struggling to latch and do some amount of nursing prior to pumping for 45 minutes. And then depending on your comfort level with cleanliness, where you live, the water quality of where you live, you're washing pump parts in between that every time, sterilizing things depending on where you live. In the United States, you do not need to sterilize your pump parts. You do in Europe. Just need to say that for everyone, right?
Yeah.
So all of those pieces together, so rarely does a provider sit you down and are like, okay, you live in Florida. You've got like a lot of air conditioning. Your house is very clean.
Yeah.
Your pump parts can actually sit on your nightstand for 8 hours. Like that's not going to cause an issue. Yeah. Does that feel comfortable to you, that risk benefit? Because the World Health Organization recommendations have to be the same in Durham as Delhi. And like those are different environments, temperature-wise, housing-wise, water-wise, right? So first we have to so the first step in dismantling triple feeding. So triple feeding is just like this blanket recommendation that's like around the clock. Do a process that takes, give or take 2 hours. And then also sometimes these babies don't take bottles super easily. So a bottle's also taking an hour. We don't have parental leave. Our spouses are back at work. Our kid maybe is in after school, our older kid. Like this is just endless.
2 hours. I mean, like exactly
2
like
hours
you said,
easy.
Yes.
And they're like, by the way, can you do this every 3?
Yes, because they're going to wake up in an hour. Like it's if you do not have help, it's already hard. But even if you have help, which I did, and I did the triple feeding journey for Vera after being hospitalized twice. I was in the hospital, left, and was readmitted to the hospital. And after that second readmission, I was like, I can't do this. It's not sustainable. And in a miraculous way, she was actually a really good latcher. And like she, even with the separation, and I was shocked because I was apart from her for 10 days when I was rehospitalized, and I came back to it, and it's like she remembered, but then it was still becoming that my supply was so low because I wasn't able to build it up because of the hospitalization that I needed better, like I needed more frequent removal, and I needed the combination, and it was not sustainable. So I had to make a decision with my colleague, lactation consultant. I was like, listen, I love this, but it's not fun for me anymore. Like I'm, like you said, looking out for the mental health. I am drained by being I'm going to use the term being a cow, where I'm literally nursing, and then I have to sit there and pump on the other side or whatever side, or right after. Yes, I had help with cleaning pump parts, but then someone had to settle the baby down, and then she was maybe clustering. It was I had to let it go.
And you're not
It lasted
getting
for 2
any
weeks.
nice time with her.
No, so you're not, and that's a key for me too. I'm like, when we talk about feeding choices and the mental health choices, what's most important to me is obviously that the baby is thriving, but that what is the connection and bonding? I would rather have a mother give or family give pump breast milk or formula and be more connected with their baby than being so stressed with the nursing or so stressed with triple feeding or combo feeding, because that stress has no place in sleep, and that stress has no place in bonding with the baby.
Yeah.
And I saw that.
So if
if
we let it be, like if we let health only be one thing, that we like
Right.
see a decline in dry skin and GI infections with breast milk feeding.
Right.
But we're not thinking about attachment at all.
Yeah.
Right? Like for me, it's like, yeah, feed the baby. Like they got to be calorically in good hands. And then right after that is responsiveness.
Yes.
Can you tell when your baby is hungry? Can you tell when your baby is full? Are you meeting that need? Because it's that connection that's what carries you all the way through parenting.
Yes.
I don't care if you sleep train. I don't care if you bed share. I don't care what you do.
Yes.
It's the responsiveness that holds you.
Yeah.
That makes us feel connected, that makes us feel human, that is the beauty and joy of parenting.
Yeah.
And if we take that away from people, and then also like sometimes if a baby's struggling to eat, they're so exhausted from nursing and then bottle feeding that they don't want to wake up at the 3-hour mark. So then you're spending 30 minutes waking them up, 45 minutes trying to get them to latch, an hour pumping and like washing pump parts and getting settled to bed. And when exactly in that did you eat a sandwich?
Yes. Or just
right?
Rest or take a shower or do something that is possible. But we when we do this narrative of it has to be the baby and the feeding and all of that, you forget yourself. And that's why we see depression.
Yeah.
That's why we see anxiety. That's why we see women lose themselves so greatly in this postpartum period and lose the joy. I'm not saying that you're going to get 5 hours of sleep and the baby's going to sleep through the night. That is not a reality, but there is a balance here of looking into what a person wants. And I think that I love when I talk to other IBCLCs who are looking at the whole body experience, and the whole feeding experience is not just for the baby, but what is it for the parent? What is it for the sleep? What is it for your situation? Like you brought up, like a second sibling. It's going to look different if you have no other baby in the house, but what if you have 2 older kids? It's going to look different. Like one other kid. What if your partner's
or a
working overnight?
Who also went through a traumatic birth and needs sleep.
Yes.
Or is working, right? Like none of it's fair.
Yeah.
So this is where I get a little off the map. And I don't know where you stand in terms of like conservative, like evidence-based, like super everything based in research. It's so hard to research in lactation. So I'm still trying to find this study. Yeah. I am like, one day someone will find this SLP study that I read once and then could never find again. Where they looked at babies in the NICU, and premature babies are often tube fed. So they have a tube through their nose to their stomach, and they're fed either formula or breast milk through that tube. And then they're sort of gradually, as they're getting older, also offered bottles or nursing to work on oral feeding. So eating with their mouth and doing that effort. And as they get stronger, as they get bigger, as they develop that motor plan, they're able to do that. And what this research showed is that the babies who were offered oral feeding twice a day were discharged totally eating orally at the same rate as the ones that were offered oral feeding at every feeding. Now, can't find this freaking study, so I can't say that this is definitive. So if anyone finds it, please send it to me.
Yes. Yeah.
But it has also borne out in my practice.
Mm-hmm.
What I experience is that babies who can and want to nurse, like you experienced with Vera, even when she was away from you for 10 days, like there is a drive there.
Yeah.
When we pace bottles, when we're being thoughtful about how we're doing things, most babies, if they can, not all babies can, my baby could not. If a baby can, they will get back to latching.
Mm-hmm.
And it seems like offering a skill twice every 24 hours keeps them pretty well in that routine.
Mm-hmm.
The other benefit that I've noticed of doing it this way, and one day I'll get the funding to actually study it, is that parents have enough oomph and babies have enough bandwidth. Where I tell people, I'm like, and for those 2 feet, those ideally 2, right? So like what I give my folks is I prescribe 4 to 6 hours of protected sleep, and I'll circle back to that.
Mm-hmm.
6 to 8 pumpings per 24 hours, and 2 nursing sessions where you are offering nursing. Now, you may get to that nursing session and you're like, I am so fried from the dog barking and the other one yelling, I can't do this. And this kid's like not interested in latching right now, move on. Like you offered it, you're done.
Yeah.
Or it could be a really effective feeding where you feel your chest after and you're like, oh, that's like nicely drained. Cool. A data point, right? So like that can run a range, but we're going to offer it twice a day. And if you have slept, you have some, and your baby has gotten some like rest, if they are working through some oral challenges, that you actually have the space to notice, is this a little less painful? Oh, it's interesting that this feeding went this way. I have the patience to sit here and try to help this baby latch for 20 minutes without feeling like I'm going to lose my ever-loving mind. Yes. And so I think there's also a real benefit to having the bandwidth to actually problem solve. So, and then what I encourage folks is like, once we've figured out the root cause, is it just physiological low supply? Is it a digestive issue? Is it an oral motor issue? Like once we figure out what's actually going on, then we can address that. If it's physiological low supply, you're just not a body that makes a lot of milk, then I say nurse however the heck much you want and supplement after that.
Yeah.
If you're someone who like maybe you've addressed a tongue tie and it's going to take some time for that baby to learn those new skills. As you notice, like, oh, feedings are getting less painful. I'm healing. That's the other one, right? Is like breaks so that your nipples can actually heal so that you can figure out how much pain you're in. Because like, I don't care if you're wearing Uggs. If you have blisters all over your feet from stilettos the night before, you're in pain the next day.
Yes.
Right? So like if you have so much pain from latching that baby every 3 hours, you can't actually tell anymore what a good latch or bad latch is.
Yeah.
So if there's a little time to heal there, you actually can get a better assessment. You can actually feel what's going on. So you feel and you're like, hey, that's not painful.
Yeah.
You went from being tight little baby to total noodle arms.
Yeah.
And my chest feels nice and soft. I don't have to pump and you don't have to do a bottle.
So, so talking about
and then we build from there. We add more as we go.
And so for that was the plan I wanted to see what your perspective was. So you said 2 nursing sessions in a 24-hour period?
That's what I offer, yeah.
Yep, 6 to 8 pumping sessions in a 24-hour period, and then ideally trying to get a 4-hour stretch at night.
But my pumping sessions, because I care more about mental health than milk production, which is my own personal prerogative, is I say, I want you to put 6 to 8 starbursts on the counter.
Yeah.
Every time you pump, you eat a starburst.
Nice.
If there's 3 starbursts on the counter at the end of the day, it's okay.
Yes. Do as much as we can.
We have miracle alternative food at the grocery store.
Yeah.
We're gonna be okay. It's a marathon, not a sprint. Tomorrow, if that does make you feel stress, if that does make you feel shame, if that does make you upset, notice it.
Yep.
Maybe talk to somebody about it. Maybe change what you do tomorrow. Maybe ask someone else to do pickup so that you can get one more pump in. right?
And with your guidance though, is it that the nursing sessions do you recommend the family or the mom pumping after the nursing session, or this is separate? Like, you know how we had the 2 nursing
you
sessions?
get to decide.
Yeah.
So usually it's after, because that's how we're going to get enough time for that big sleep.
Yes.
Right? So usually folks pump right after. If that just like doesn't work in your day, and it makes more sense to pump an hour apart 2 times close together in the evening when the kids are in the bathtub. Right? Like, okay. Because at that point, I'm not super duper I understand that parents are super focused on like enough output to keep up with their baby. But for me as a clinician, I'm just focused on spiking those hormones. So if I'm spiking those hormones 6 to 8 times a day, I'm happy.
Yeah.
And so it doesn't have to look perfect. It's not supposed to be all the way around the clock. So I would rather, instead of being like, at 2 p.m., you're going to nurse and then pump, like that may help you to write it out like that. But in terms of what I'm offering is like, look at your day. What are your chill moments? Like that nursing is going to happen for you maybe at like 10 a.m. after you've had coffee and breakfast and like everybody's a little chill. Or maybe it's 3 a.m. because that's when your house is quiet and you actually like feel sort of more connected and your baby's sort of drowsy, snuggly. Like that just can look different for different people, and that's okay. And so the other really big piece of this is protected sleep. So this comes from research. Again, everything in lactation is hard to study, so I pull from other fields. But in mental health research, specifically around complex mood disorders, and is that folks who are experiencing anxiety and depression, specifically kind of around like bipolar disorder things, which while not bipolar disorder, most people who are experiencing postpartum complications experience both anxiety and depression or some combination there. So we know that one of the things that helps reduce symptoms for folks that actually do have a bipolar disorder is protected sleep.
Yes.
So with a newborn, we only have so much wiggle room we can do with that. I can't say like 8 hours dead on. If you're having a serious postpartum mood issue, I am going to recommend that. And I'm going to look your mother-in-law and your spouse dead in the eye and say, this is not negotiable. This is a prescription.
Yes.
This is not a treat. This is a prescription.
Yeah.
And we may need it for the spouse too, right? You may be trading off. For folks who are sole parents, I'm like, is there someone who can come over at 5 p.m. and stay till 10? Like, can they come over after work? Right? So like, where is there a 4-hour chunk?
Yeah.
Where white noise is on, earplugs are in, baby can be in a carrier with a pacifier walking up and down the block. I do not care.
Yeah.
But the rule is that no one's going to wake you up so that you know you can go to sleep and you're not sitting there being like, at what point is this baby going to wake me up? I'm so anxious about it.
Right. You're not in an elevated like anticipation sleep. Yeah.
It's like no matter what, they're not coming in for the next 4 hours. Ideally, your phone's in the other room, your earplugs are in, and you're in full do not disturb mode. And then you notice, after that 4 to 6 hours, did you feel better? That's important information. We should stay with the plan. Seems like your mood disorder or like your anxiety or depression are like in a controllable range or not present. If you wake up and you don't feel better and you feel anxious, you're having intrusive thoughts, you feel depressed, we're going to talk to your provider.
Yeah.
If you were given that opportunity and you cannot sleep, that's when we need to go up to the next level of care. And I actually want you to call the 24-hour line of your birth folks and say, hey, this is what's going on. I want y'all to know about it. And like, we're going to make a plan in the morning. And that might involve medication. I'm on medication still from my perinatal mood disorder. I take an anti-anxiety medication that's been really, really helpful for me. And when my daughter was born, I actually would take Klonopin to sleep because my anxiety was so severe that I couldn't sleep when I was given the opportunity. And I was really losing it with the sleeplessness. And eventually I backed that down to Unisom, and then I backed that down. But I think that's the other piece is like sometimes you actually also need medication just to get the sleep that's going to help you heal.
You know what I found interesting, and we talk about the sleep protection, I actually agree. And I agree completely that we don't have a lot of research in the lactation world, especially in anything pediatric, but it's unfortunate. But I had a lot of postpartum issues physically, right? I was recovering from multiple surgeries, in and out of hospitals, on tons of antibiotics. And I also had a postpartum doula who came in and she's like, Mona, I need you to get sleep tonight. You're going to sleep for 6 hours. You're not going to wake up. You're not going to pump, and you're going to sleep for 6 hours. For me, and I'm not going to say that this is going to happen for everyone, that night, when I got 6 hours, my milk production skyrocketed, which means for the next few days and to come, all of a sudden I was producing more milk. And I say this story because, all the recommendations will say, well, you got to wake up every 3 to 4 hours, or you got to do this. For me, my body needed the extra sleep to be able to rest and then subsequently produce more milk. And it sustained. All of a sudden I was producing more milk. And I don't know if you have any research on that or know about that, but to me, that's why I was, and then I obviously kept it there. And then I started to increase very slowly the 6 hours or the 7 hours or whatever to see if it would help my milk production. And I found a happy spot for me to find out what is my sleep quota that allowed me to obviously not tank my supply. And in a way, it actually increased my supply. And it was fascinating to me. And it makes sense. And described, like, I did have anxiety prior to having my daughter, and I still had it. And I wonder, like you said, is it that my body just needed that rest, but also that rest really helped my body heal and my milk production went up. And I don't know if you see that in your training or in your experience too.
I haven't seen that researched. And sometimes we have to rely on like our medical brains and what is physiologically logical.
Yeah.
Right? Like if you have a patient who had surgery and they're like, great, I don't plan to sleep for the next 6 weeks, you would anticipate surgical complications.
Yes, absolutely.
And very slow healing.
Yes.
And we know that our body systems interact with one another. We know that our bodies will shut down a system, right? I have known folks who have no other signs of low milk supply, but their body experienced shock postpartum from a postpartum complication. And their body was like, I'm not making milk. Sorry. I got to keep you alive. So the people for whom I see that most true are people who had a lot of blood loss or for people who had surgery. So a cesarean birth, or for people who had a hemorrhage. Those are the people for whom I think sleep is going to make the biggest difference because your body has to actually make more tissue, right? Human milk is tissue. That's a lot of energy, a lot of hydration, a lot of work to make that tissue at the same time that you're trying to make blood, that you're trying to make scar tissue, that you're trying to make new uterine tissue, right? Like is it 8 layers? Of a cesarean, that's a lot of your body.
Yeah.
I think birth is gross and weird. I don't pay attention to it.
Twice.
Right? So like your body is working so hard. And so I think for those folks, like for me, over time, that like ounce or two of milk production every day isn't worth not sleeping and recovering well. And you're right that it makes physiological sense that more sleep would allow healing in other parts of the body, which is going to allow you to recover and then be well enough to make milk. And then different people have different storage capacities and different bodies. And that's part of it, is to be like, triple feeding is this monolith that also doesn't take into account that like some folks can actually skip a pumping. It's your 5th kid, your milk supply is really well established, like you have oversupply, actually pump less, right? Like to be nuanced in that.
That's what happened for me. I started dropping sessions before official, when you look on other, accounts, and I was going down and I still produced. And like you said, when I got readmitted to the hospital when I was postpartum, that is also when my milk supply went up because I was getting 4 hours uninterrupted sleep. There was no baby with me. My baby was at home with the family, and it was like and it makes complete sense. The fact that I had 2 surgeries, my body needed to rest that tissue and really create it. And like you said, this is such a nuanced discussion, and why it's not such blanket recommendations, and why I wish we had just better access to a whole team of like lactation consultants that are not just lactation consultants, but lactation consultants that are kind of in your perspective of looking at the whole family unit, and I think that's so important.
My hope is that as a field, we're moving towards really thinking clinically. I think for a long time we were fighting with peds to not just recommend formula.
Mm-hmm.
And I think now PEDS is really bumping it back over to feeding specialists to fill in that space. And I think we have to really rise to the occasion, really think critically about what's happening and really build those tools and not be quite so focused on one way of breastfeeding or on the importance of breastfeeding and breast milk feeding, and instead look at ourselves as the foremost experts in infant feeding.
Yeah.
And let that be as complicated as it is.
Oh, I love it. What would be your final message for everyone listening today? I mean, you had a lot of pearls, but what would be that take home?
I think my take home is let your story be your story. Find the parts of your journey that you want to hold onto and lift those ones up and let the other stuff go. I often say good parents change their mind. It's not about the fact that like, well, I read the Montessori parenting book, and so I'm going to do Montessori and Moms on Call, and I'm going to do exactly what Dr. Sears said, and I'm going to follow all the rules. No.
Yeah.
I'm going to look at my life. I'm going to look at the baby in front of me, and I'm going to change my mind and follow what is working for us.
Oh, such a healthy perspective. I love chatting with you. I cannot wait to read your book. I cannot wait to connect on future education. I want you to be my mentor. You talk to me about your mentor in terms of IBCLC world. I just love where you're coming from and what you're trying to share with the world. Where can everyone stay connected with you and your resources and also get your book?
You can find me on the socials, Victoria Facelli, IBCLC. And my book is available all the places books are sold. It's at your library. It's at your local bookstore. It's in the Target app. It's on Amazon. You could probably get it overnighted.
I will be linking everything to my show notes, including obviously her social channels as well as the book. And I'm going to be buying it as soon as I get off this call before I record another podcast because I cannot wait to dive into it. And thank you again for joining us today.
Thank you so much for having me. It's always so fun to talk to someone who shares so much of my perspective, both professionally and my experience personally.
Yeah. And I love, like you said, going back to that first thing you mentioned about pediatricians and why we're the way we are. I agree with you completely. I think there needs to be such a rehaul. And I think we're moving in that direction. I think a lot of the younger pediatricians understand that we don't know everything and that we need to use our resources, where I do see a lot of older docs trying to do things that maybe they don't know much about. So, and even for me, I'm very transparent in saying that although I am an IBCLC, I don't have as much training in IBCLC education as you do, or as my colleagues who do it way more hours than I do. So I get to learn from you. I get to keep growing. And I think that's such a healthy perspective, like you said, to not only as parents to always pivot and grow, but also just as professionals. So thank you. I loved connecting with you.
It was so great to connect. Yeah, and I don't think we need pediatricians to all be IBCLCs, though I love that we have IBCLCs who are engineers and dietitians and speech therapists. It's about understanding where's your provider coming from, what's their background, and what does their lens necessitate that they put first. And I think as long as we're all working together collaboratively and parents understand what is the role of their pediatrician and what is the role of a feeding specialist and why are those different and where do they overlap and how can they work collaboratively, is where we actually pull this field forward.
Absolutely. And for everyone listening, if you love this conversation, which I hope you did, even if you are not a nursing, pumping, breastfeeding family, I don't care, please leave a review, rating. It really helps the podcast continue to grow. And I'm sure I'll have Victoria on for future conversations about IBCLC life and newborn feeding. Thank you so much.
Thanks for having me.
Thanks for tuning in. If you love this conversation, make sure to hit that thumbs up sign, share this episode on your social media channels, and subscribe to this channel to stay up to date on all future episodes and our weekly educational videos. Have questions or comments? Make sure to comment below, and I'll see you all next time. Stay well, stay loved, and keep on shining.